Everyone. Hi, everyone. Good morning, good afternoon, good evening. Welcome to the Global Evaluation Week. My name is Negusu. I'm the Design Monitoring Evaluation Specialist with World Vision US. So I'm joined today by two wonderful colleagues, Pascal is a monitoring evaluation specialist from World Vision South Sudan, and Lilian, she's a senior research executive at Pan African Research Service from Kenya. So today we'll take you through evidence gathered from a rapid assessment of GBV referral network. Therefore, the session will highlight critical gaps in access to GBV services, barrier faced by survivor in fragile context, and also practical evidence-based recommendation, just to strengthen survivor-centered response systems. So before we dive in, let me give you a quick sense of how the next hour will flow. So Pascal will take us through the context, objectives, and methodology of the assessment, grounding us why this work was needed and how it was done. And Lilian will then bring the findings to life, drawing on the surveys, focus group discussions, and key informant interview with the health workers, police, and even NGO. And then I'll close with system level observation and also our concrete recommendations for practitioner and policy makers. I'm now delighted to hand over to Pascal. Pascal brings over 8 years of experience in monitoring and evaluation in fragile and humanitarian context, and he has been at the heart of the ACRP2 program in South Sudan. It was funded by World Bank, and he led also the coordination of this assessment on the World Vision South Sudan side. So Pascal, the floor is yours. Thank you.
Yeah, thank you so much, Negusu. Hello, everyone. Welcome to this important session where we are going to share and reflect on the findings of our assessment of the GBV referral network assessment, which represent a critical step in our collective efforts to strengthen the support system for survivors of GBV, ensure effective coordination among service providers, and ultimately foster safer, more responsive communities. In my presentation, I will look at the context of South Sudan in terms of GBV, and it is where the assessment was undertaken. We'll look at the objectives of the assessment, the methodology employed, demographic findings, and the existing referral pathways. Just as we have heard from Negusu and Lilian will present other parts of the assessment. Yeah, just to dive straight to the context. In South Sudan, particularly in Twic and the Gogrial West of Warrap State, where ECRP project is being implemented, there are a lot of GBV and protection issues. So desk review conducted in March 2025 in Gogrial West and the Twic County by World Vision South Sudan under enhancing community resilience and the local governance project, a project that is funded by World Bank through the Ministry of Finance, focused on the situation of sexual and gender-based violence. So findings revealed very concerning levels of violence, including domestic violence, sexual assault, and harmful traditional practices. There are serious issues affecting the safety and the dignity of many individuals, especially women and the girls. So, however, of the main challenges we face in the main challenges we face is that though these cases are happening, the survivors I do feel reluctant to report it. So it is one of the issues that we face. So this underreporting happens because of several reasons. One is stigma, which makes victims afraid to speak out, a lack of trust in law enforcement agencies, limited access to justice and health services, and insufficient support system for survivors. So under this World Bank project, World Vision does not directly implement gender-based violence intervention. Instead, we mainstream GBV and SIA into our broader program activities, such as awareness campaigns and community engagement initiatives. Our goal is to raise awareness within the communities and create a supportive environment where victims can seek help. When we identify cases of GBV or SIA during our activities, we ensure they are referred promptly to appropriate support services. This approach helps us to strengthen the overall system of support and ensure timely assistance for those in need. Despite efforts by the government ministries and the partners implementing some projects in Warrap, such as creating SOP, conducting awareness training staff, and providing integrated services. Many obstacles still remain despite all these efforts. Reducing the awareness of these programs. So to better understand and address these issues, World Vision, under the project that I spoke about in, I think, community resilience and the local governance project, a project that is funded by World Vision, contacted the African Research Service to conduct a rapid assessment of GBV referral networks in the two counties, Gogrial West and Twic, in Warrap State. The goal was to identify gaps and find ways to strengthen the system so that survivors can access timely and adequate support. So in summary, well, significant efforts have been made to combat GBV and improve support system. Ongoing challenges mean there is still much to do. Improving reporting, building trust, expanding services, and strengthening referral networks are crucial steps towards protecting survivors and ending violence. Next. So in terms of the objective of the assessment that was conducted, the first objective was to assess the landscape of GBV services and the referral pathways at the county, in the two counties where the ECRP project is being implemented. Evaluate the coordination among the stakeholders and the community involvement, evaluating collaboration between service providers and the role of communities in the referral process. Evaluate the quality and responsiveness of GBV services. Identify key gaps, barriers, and factors influencing the effectiveness of the referral network and service delivery. And lastly, provide actionable recommendations to strengthen the GBV referral system, improve service quality, and enhance coordination among service providers and stakeholders. So next, Neguso. Looking at the methodology, the assessment used a mixed methods approach, combining household surveys that where 520 respondents were interviewed, key informative interviews with government, NGOs, and community leaders, and a focus group discussion with survivors, caregivers, and community members. Of these, 61% that represents total of 319 respondents were interviewed in Gogrial West, and 39% that represents 201 respondents were interviewed in Twic County. Male respondents made 43% of the sample, and female were 56% of the sample. The assessment triangulated the quantitative and qualitative data to provide an evidence-based understanding of service availability, coordination mechanisms, referrals practices, and barriers to GBV response. 10 FGDs were conducted targeting adolescent boys and girls between 15 to 18 years and adult men and women above 18 years. The following key informants were also interviewed: health facility staff, that comprises of nurses, GBV focal points, social support officers, case managers, police or protection officers, legal aid, paralegal staff, community leaders, chiefs, NGOs, representatives, BOMA committees, and case management respondents. Next. In terms of demographic findings, a total of 520 respondents were interviewed with diverse representation across the two counties and the age group. Looking at the geographical distribution, Gogrial West County accounts for 61% of respondents. That is about 319 individuals, indicating significant participation from that county. Twic County accounts for 39, representing 201 of the targeted respondents. From this finding, as we have seen, 30% of the respondents are youth aged 15 to 24, about 156 individuals. This underscores the critical role of youth, of young people in the community, and the importance of youth-focused program. In terms of gender distribution, 221 respondents were males, accounting for 42%, and 299 females, accounting for 58%, showing a slight female majority in the sample. In terms of disability status, a majority of the respondents, that is 507 out of 520, that is around 97%, reported having no disability. A small portion of 13 individuals reported having a disability, emphasizing the need for inclusive approaches in any service that is being delivered. In terms of educational attainment, literacy levels are generally low across both counties, with only 2% of respondents having post-secondary education. A significance of 65% of respondents have no formal education, indicating challenges in educational access or retention. Next. Looking at the existing GBV referral pathways, it outlines the critical roles being played by various organizations and the essential services they provide to support GBV survival at different stages. These pathways, have made partners work to ensure timely response, protection, and empowerment for those affected. So, though there are few challenges, these partners you have seen, in this slide here, they try their level best to make sure they coordinate the service, the service to the GBV survivors. One of the service point in Gogrial West and Kwajok in particular is the state hospital. That provide number of services such as emergency medication, including post-exposure prophylaxis to prevent HIV. Then another service they provide emergency contraception within 124 hours to prevent pregnancy. Diagnostic tests for common disease that they do if a survivor comes to the facility. So they also do referral services for further care. So if whatever they don't have in the hospital, they also refer for further responses. Mental health and psychosocial support is also being provided at that hospital. So in Kwajok also, there is a partner called Touch. They deal with GBV and protection. The services that they are being provided by them is psychosocial support and counseling, emergency cash assistance for GBV survivors, clinical management of rape cases, referral services to specialized agencies, provision of dignity kits, legal support, GBV coordination, and advocacy efforts, including ending early and forced marriage. So they advocate for ending early and forced marriages. So, World Vision in Warrap and Kwajoko in particular, they have a general protection support, and what they do here is overall protection and coordination and advocacy for GBV. That is being coordinated by one of our colleagues. So we have action against hunger that also operates in the Gogrial Wealth. So they offer awareness raising and data collection on available services. They also research and look for GBV survivors in the communities. When they find it, they also refer for GBV services. Another thing they provide is the field-based case management in women and girls-friendly space in Gogrial East and the Tone North. They also do psychosocial support and case management. Police Special Protection Unit in Kwajok, that is under Gogrial West, so they have a number of services that they offer. They provide legal services, giving from aid, conducting investigation, and also referral. So we have prison also that also support GBV survivors. So they also offer psychosocial counseling, refer some of the cases to agencies for support and other services. So we have the State Ministry of Health, State Ministry of Information. So what they do is radio talk show on GBV program, promote advocacy through interviews, recording the advocacy functions, and the sharing of the information through media. So we have Women for Change in Kwajok. They have a number of services that they are providing. One of them is psychosocial cycling, psychosocial support, case management, women empowerment, and business skills. And then we have a Twic also that operates in Twic. So they offer a number of services like women and girl-friendly space activities, psychosocial support session, life skills activities. So we have unimis that also supporting doing awareness and also advocacy. Then in the Twic we have GIFAs that have number of services that they are providing, like basic counseling, case management, referral, and mobile case management response, dignity kits that they provide the GBV survivors. So I think those are the services that are being provided in different referral pathways that we have seen in this slide. So this brings me to what I wanted to share, and I beg to stop here and over to my colleague Negusu. Over to you, Negusu, and thank you.
Okay, thank you very much, Pascal, for the wonderful presentation. Now, the second presenter is Lilian. So Lilian is she's an economist and statistician with over 5 years of experience in mixed method analysis. So she's based in Kenya, and she has also a lot of actual experience related to GBV related, and she went there to the field during the field assessments. So Lilian, over to you. Thank you.
Okay. Hello everyone. Thank you for joining us today. I'll just pick right from where my colleague Pascal left. So he has taken you through the referral pathways that are currently existing in South Sudan, particularly in Twic and Gogrial counties of Warrap state. So despite these services being there, we still noted that there exist a various number or a lot of significant challenges that impacted on how effective this the referral systems were working. So we evaluated the effectiveness of the referral systems in terms of timeliness, how fast they respond to issues around GBV, affordability of the services to the community members in terms of need, and of course, when we're talking about GBV, an aspect of confidentiality is very important to assess. And I'd say maybe the best performing in that particular setting, the best performing referral pathway was psychosocial support system and case management. And this was noted, it was highly because these were offered by partners in the space, that is NGOs that were working in those areas. So despite it being reported as being timely by 51% of the community members, you note that there still exists about 49% of the community members who have not been able to access psychosocial support and case management systems in need. And you understand that conversations around GBV, when you're talking about anything to do with GBV, reporting and how fast the case is handled is very important into how the final verdict of that case, or even the opportunity for the survivors of GBV to get justice would likely to be. So yeah, the psychosocial support services. We also have protection and safety services, performing well below average, and then community-based prevention and awareness services, health or medical services, legal and justice services, and then lastly we had the livelihood or economic empowerment support services. For livelihood and economic empowerment support services, this was mainly due to the fact that it takes some time for community members to start enjoying the benefits of any livelihood interventions. The benefits are not seen immediately. And then we also noted that a lot of the organizations that are working in this space, and I think these can be something that us as researchers as well as implementers of programs can think about. We don't focus a lot on the sustainability of the interventions. So we realize that if the organizations that are supporting the communities to empower them and be able to improve their lives so that they can reduce their vulnerability to GBV cases, leave the community, and so the community is left like that. And therefore, these people go back to the same households that they were attacked or they experienced the GBV cases. Of course, closely related to that, we have legal services, which is key when we are trying to acquire, to ensure justice for the survivors of GBV. Unfortunately, this is very lacking in the counties that we went to. For instance, to paint a picture, Warrap state is about 31,000 kilometers squared. And in the whole of that county, there is only one judge that is responsible for handling all the legal and judicial cases. So you can imagine, and the judge is based in Kwajok, that is in Gogrial West. So all the community members that have issues, be it issues to do with land, be it issues to do with civil cases, be it the GBV cases, they have to depend on this one judge to be able to listen to the cases and offer any judicial verdicts and all that. So that was also very lacking. Of course, there are no public provided lawyers or attorneys to represent survivors of GBV, and most of them now they are posed with the issue of deciding to spend a lot of money with the private law firms to be able to follow up with their cases. Of course, this being a fragile context country or counties, we know that is a challenge. So the opportunity cost of them choosing to pay private law firms against them being able to afford their day-to-day basic needs is very high for them to risk that. So that's, we end up with a lot of unreported cases. Next slide. Okay. So despite the challenges that we've talked about, we noted a lot of positive changes that are happening in the community, and a lot of this is because of the collaboration that we've seen in the community between the government and the NGOs and other partners. So the first one is community engagement. Of course, we noted that traditional leaders, women groups, and youth, there's been an increase in awareness and knowledge about the existing referral pathways in the counties, and this was majorly because of the GBV cluster in the county the counties have been organizing a lot of campaigns. They've been publishing posters and just trying to inform the community on what other pathways or what steps they can take in case they encounter a case of GBV. And then NGOs and partner support. Of course, a lot of the NGOs that are working in that space, whether they are focusing on maybe WASH aspects or nutrition or health, most of them we were able to see that they've integrated aspects of GBV into their messaging. For instance, SCF, Action Against Hunger, for them, they are, as much as the projects they have are nutrition focused, they try anytime they're doing the distribution of the foods to the community, there is always an officer that is educating the community members about issues to do with GBV. And then health facilities, for these ones, we saw that hospitals and primary health care centers have done their best with the little resources they have to try and ensure confidentiality and providing a structured way of handling cases so that in case one officer is not around there, the one that steps in is able to know how to best respond to these cases. Of course, the health sector is facing a few issues here and there that we've talked about and we'll still talk about them. But yeah, that's what they are doing. And then for the legal system, though this one is still a proposal, it has not been implemented, but there was a proposal to have mobile courts to be able to speed up the GBV trial process. But due to lack of funding and coordination, this was, as of today, it has not yet been implemented. So it's just a policy that is in the books. And then lastly, we have police collaboration. And this one, we can allude a lot to what UNIMIS are doing. They've been doing a good job at empowering the law enforcement officers into having better understanding of how to respond to cases of GBV and how to handle the network, use their networks, the community networks, as well as engage traditional leaders to be able to improve the process of reporting GBV cases. Next slide. Okay, so when we talk about the staff capacity and training, so here we are looking at the staff that are responsible for the day-to-day handling of cases. So we'll start with the NGO and UN efforts. So for example, we have SCF, GEFAs, and Women for Change that have been supporting the community. And for them, what some of the for the key informants that we talked to, it is a requirement that all officers that work in the community are educated on how to respond to GBV cases, so the GBV case management. They've made it mandatory for their staff to undergo psychosocial support training so that when they're implementing projects in the community, they're able to support communities at that time. And then also they've been educated on the existing referral pathways. Unfortunately, for the healthcare service points, there we noted a lot of gaps. The way South Sudan is structured, one county has only one primary health care, I'd call it primary health care center. And then as you go lower into the geographic distribution, you have primary health care units. So unfortunately for these primary health care centers, they lack resources. The officers there, all the officers that we talked to affirmed that they've never received any specific training on how to respond to GBV cases. So all the training that they have is what they learned in school. And you understand that in terms of how we respond to GBV cases, sometimes there are unique situations or there are unique ways in which we have to support GBV survivors. So unfortunately, that's the situation. And there are even cases where a health worker is not able to support a survivor of GBV because they lack something as simple as gloves. So yeah, and then for the police officers, while organizations in the space such as UNIMIS, I mentioned that, have tried to empower them in terms of offering them training on how to respond to GBV cases, this is inconsistent because of a lot of police officers tend to leave the community and try to go to other countries or even the capital city of Juba to look for better opportunities. So which means as they leave, they end up, there's a gap is created. So there's inconsistent training between the officers. And then unfortunately, some of them still have the traditional mindset of trying to solve issues within the community without engaging law enforcement. And we noted that in most cases, the survivors of GBV, especially if they are girls, will end up being married off so that they cannot, the community terms it as trying to not bring shame to the family. So there's still some belief, especially in the law enforcement officers, that goes against what we are trying to improve on how we respond to GBV cases. And then lastly, we have legal and community gaps. This one I mentioned. There is minimum legal support that is afforded to the survivors of GBV to be able to process their cases. Next slide. Okay. And then we have safety, confidentiality, and cultural practices. So the NGOs and the health workers have tried to incorporate private spaces where survivors of GBV can be evaluated and assessed. And then there's also secure record keeping. This again has been really supported by the NGOs in the space through capacity building the health workers on how to record and report cases of GBV. And then, of course, there's consent-based referral. They've been educated on that. And then we have police officer failures. This one roots from the inconsistent training. In most cases, they end up returning the survivors of GBV back to their communities or their guardian or the family that orchestrated the whole incident. So there's still failures around that. And then we have cultural barriers. So when it comes to how cases of GBV are perceived, there still exists a lot of stigma and tradition beliefs around it. And so even talking to some of the community, how would I call them? Some of the community leaders trying to discuss issues of GBV with them is shunned upon. It's not a conversation they are open to having at this point. Of course, a lot of awareness and capacity building needs to be done to improve this, but yeah, that's the situation at hand. And then lastly, I think for training, I've talked about it. We can go to the next slide. Okay, so overall, we noted that there exist very few health facilities, and then community members have to cover very long distances to be able to access health services. There exists a one-stop center at the capital of the state in Kwajok, but then if you look at community members like in Twic counties, they have to walk for over 12 hours to be able to access the one-stop center. So most of them, it poses as a challenge to them. They have to choose not to access these services. So other issues that are affecting community members in terms of accessing the services within the referral pathways, we have economic or affordability issues. I talked about high legal fees that are charged by the private law firms, poor infrastructure. So the transport system there, especially the public transport system, is not very developed, and then most of the roads are inaccessible, especially during the rainy period. So we talk about 72 hours or 48 hours to be able to report certain cases depending on the nature of case that we are handling. And you see, if the community member has, or the survivor of GBV has to spend over 12 hours on the road and being rained on, even preservation of evidence poses as a challenge to them. And then, of course, there's the issues of limited awareness. Most community members there are some practices that community members in these areas still feel are part of their traditions, or don't ideally consider them as issues of GBV. For instance, there were cases where a partner was beating the other one, and when this was reported, the police officer said that's a family issue. You need to go and solve it within your family. Or cases where a child is defiled, and then the father goes ahead and asks for dowry, and the child is married. Children as low as 10 to 12 years. So yeah, there's little awareness on what exactly is defined as GBV and what isn't. And then there's untimely service delivery. I talked about that. And then shortage of skilled service provider. I talked about that. But you can see the greatest challenge that we have there is the existence of very few health services and long distances that need to be covered for them to access the services. Thank you, Niguso. I think that's it from me.
Okay, thank you very much, Lillian, for the brief and insightful presentation. Now I am going to present about the gaps in the referral system. So I'm Nigisu, design monitoring evaluation specialist with World Vision United States, based in the Washington, D.C. So I have more than 18 years experience across humanitarian and development context. So I'm supporting the humanitarian emergency efforts grants across Latin America, Caribbean, Asia, and Pacific and Eastern African regional office. So I'm going to present the gaps basically in the referral system. I know Lilian has already mentioned, so I can start a few summaries. So the first one is the gaps in the referral system, the breakdown as service pointers. So these referral systems are as weak as you have already heard, with very few cases forwarded from health facilities to police, courts, or psychosocial support, and even just poor follow-up by staff. So this resulting in survivor care dead ends, and even police resource also limited. So a functional referral pathway means just that when a survivor enters the system at one point, they take an example at the health facility, they are actively guided to the next services they need. But what the assessment found instead was a series of dead ends. I'll give you some example. Even at Akon Primary Health Care in Gogrial West, the case management officer confirmed that they had referred just one case to the police and none to the courts or to the psychosocial support. So two cases were even referred to the NGO case workers, but nothing was done because the case workers didn't even respond. Even staff at the facility, even they don't conduct even follow-up. So they have no system to track what happened to the survivors after they left. For those survivors, if you take an example, Akon Primary Health Care was the last stop in the referral chain. It's not because they got everything they need, but because the next link even didn't exist. So that's one thing. And the other one is even officers in both counties, in Gogrial West and Twic counties, they cited also lack of Form 80. This Form 80 is actually, it's a basic documentation form, so as a recurring constraint. So without Form 8, survivor can receive formal medical examination, just for legal purposes. So the result is that some officers even ask survivors or their families to pay for the form themselves, or just for transport fees. So even families, even who cannot pay, drop the case, and those who pay experiences also at corruptions we'll see later, and lost even trust in the systems entirely. Even workers at the Gogrial primary health care, even they described having no gloves, even to examine bleeding survivors. Even Mother Teresa Hospital reported even no rape kits available for menses. So without basic equipment, even willing and trained health workers, they can provide even the clinical management of rape that survivor care requires within the critical 7-hour window. And one of the health workers at Gogrial primary health care mentioned that we don't have the relevant equipment to support survivors. Like if I have a survivor and they are bleeding, no, most times we don't even have gloves. How do I attend to them? So I can't fully help them. So that's what they mentioned. So generally, this is one of the gaps that we observed. And the second one is weak legal pathway. So as you have already heard previously, especially judicial bottlenecks exist due to a shortage of judges and even slow court processes. So this causing actually delays and even case drops. And even mobile court offers some relief, but still are not yet widespread. So even when a survivor navigates the police and receive medical care, then they face even, the legal pathway. And even it is the weakest link in the entire chain, as I think I've seen it in the previous slide. So the entire state of Warrap, that is the 6 counties, even thousands of GBV cases has just one judge. Do you remember what Lilian has already mentioned? So it's one judge, it's one based in Kajok, a survivor from Twic County, which has no court, must travel to Kojok, actually, just to pursue any legal cases. So that journey can take more than maybe just a full day or it's like 12 hours. So during the rainy season, even I was there 2 years before, even the roads maybe it's impossible, and even when they arrive, their case may be also postponed because that single judge is already overwhelmed, and many survivors they simply gave up. Okay, so that's one of the challenge. Even in Twic County, there are no governmental funded lawyers at all. Survivors even must either pay private law firms, which was not, can't afford for them, or they forego legal representation entirely. Because in Gogrial West, Twic provides one pro bono lawyer actually at the one stop who can't pay, but the one lawyer for the entire county. So that's why when asked about providing legal aid to those who can't pay, one private practitioner, they responded that, no, our service is purely business. We can't do it for free, you see. So mobile courts were even proposed as a solution to bring justice, just closer to communities. But the newly elected governor, they expressed commitment to reduce, case backlogs through this mechanism. But as of the assessment, mobile courts remain non-functional. So the proposal faces, financial challenges has not been even implemented. So that's one of the issue. And the other one is insufficient and under clear pathways. So this is actually, referral options are limited outside the capital with few service providers and little clarity on referral routes. So vulnerable groups like, person with disabilities lack also specialized support. Now, beyond the specific breakdowns we just described, there is a broader or more fundamental problem. If you look at in many PAMs, survivors, they don't know where to go. There are not enough actors, just to refer them. And even the pathways that exist are not clearly mapped or communicated. So in Twic County, as of the assessment, as GFAS is the only NGO actively supporting the GBV referral network, and GFAS provides psychosocial support and case management and even vital services, but it doesn't cover legal or residential shelter. So there is no organization doing protection case management in Twic. So no organization running a residential safe house. So the referral pathway diagram for Twic is, in practice, it's a very short chain. I think, as you can see from the previous even slide deck that Pascal has been already presented. So even if you look at the person with disabilities are particularly even under-reserved, Even not a single organization in either county reported having a specific pathway or tailored protocol for survivors with disabilities. So as one of the health workers acknowledged, we treat everyone equally. But this is also a gap because persons with a disability often need, additional considerations like special transport, tailored counseling, and assistive communication, which we currently lack. So that's what they have also mentioned. And the other one is failure of law enforcement. So police often, neglect cases, sometimes even sending survivors back home without even protection or legal actions. Although laws exist, enforcement is weak, due to cultural awareness or, resource challenges. So even the police are the most common first point of contact for survivors, right? But if you look at the finding, 96% of reported cases in Twic were brought to the police first. So what happened at that first point of contact matters immensely, right? And what we found is deeply troubling because in multiple communities, survivors, they describe police officers sending them back home even without taking action. So without a referral to health services, without a statement, so even without a Form 8, that's the essential medical, document form that connect the police system to health and to the legal services. Even survivor reported that, system neglect, cases handled dismissively. Survivor even returned to unsafe environment, perpetrators even facing no consequences. So that's one thing. That's why training is inconsistent. Even, the police inspector confirmed that even the majority of the officer under his command had never attended any GBV training. So they relied entirely even on their general understanding of the law. So that's the failure of the law enforcement.
Excuse me, Niguso.
Yes.
Kindly check the method that I just sent you. Thank you.
Okay. Okay, so when it comes to the centralization of services, it's basically essential one-stop centers are centralized in Kajok. So basically, this is creating major geographical and safety barriers. Okay, yeah. Okay, so the other thing is the one-stop center in Kajok is a genuinely good model. If you look at the Kajok one-stop center, it provides integrated medical, legal, psychosocial support, case management services under one roof. So it was established precisely, of course, just to reduce the burden of the survivor having, just to navigate multiple disconnected service points. But it's, service 6 counties from one location. So that's why, for survivor into reaching Kajok takes more than a day's travel. For survivor in remote PAMs with Gogrial was some walking 40 to 60 kilometers to reach even the nearest primary health care services. So that's why the journey to Kajok is not possible, especially during the rainy season. Yeah. The other my last point is about the multi-sector coordination challenges. So let me quickly discuss on the multi-sector coordination. So as you can see here, basically GBV response is inherently multi-sectoral. From health, legal, psychosocial, protection, community system must work together, right? Because this is, it's not like, one activity. It is the multi-sectoral. It is inherently multi-sectoral because there must be an integrations for the health, legal, psychosocial, protection, and community system. So coordination forums exist in principle. If you look at in the 2 counties, there is a coordination forum exists. Monthly GBV coordination meetings have been mentioned by some actors, but because of the geographical barriers, poor communication infrastructures, and now because of the short, as you know very well, the funding shortfalls, So these meetings are inconsistently held and even, unevenly attended. So that's why information is not systemic shared across sectors. And even the referral feedback loops even is do not functional. So that's why even a survivor referred from the health facility to an NGO co-workers may never even be followed up. So that's one thing. And the other one is, the community structure. The chiefs, the Boma communities are in some areas, they're doing the work that formal systems, but they lack, the mandate, training, or just the resources to do systematically. So when their cultural framework of GBV conflict with the surveillance center principles, they can inadvertently become barriers rather than bridge. So that's one of the challenges. And even the systemic implication is also clear. But the problem is coordination must be also formalized, and even ad hoc communication, goodwill-based cooperation, even cannot sustain a survival center system. So those are actually some of the challenges when we are talking about the multi-sector coordination. So when it comes to comparison to the global standards, so where do we Twic and Gogrial stands against global standards? So the first one is, if we look at on the coordination, I know we have 5 minutes, but I just want to highlight the key points only. When it comes to on the coordination, the global standard mandate formally multi-sector coordination. What we found were informal relationship, case-by-case coordination, or no formal county-level mechanisms in Twic. So that's one of the issue or the challenge, because if you look at here, so this is basically, if you look at here, the intelligence minimum standard for GBV in emergency. Maybe you can check that one, because we are comparing with, it's developed by the GBV area of responsibility and also the ISAC GBV guidelines. So we just compare actually with that global standard, okay? So that's one of the things. On safety and confidentiality, global standards require, private space, secure data management, and informal consistent at every steps. Some facilities have made, meaningful progress, particularly, especially for the Mother Teresa Hospital, but inconsistency remains a norm. So that's one of the issue. On accessibility, the gap is stuck. Global standards call for service accessibility, regardless of, geography, disability, age, or displacement. But if you look at services in Warrap state are almost entirely centralized in Kajok. So accessible to survivors, from the immediate area, but not from Twic, not from the remote PAMs, not during even the rainy season. So that's one of the things. And for the last one is on the monitoring and evaluation, especially the global framework require robust data collection and referral tracking. What we found was a system where no public official could, definitely say how many GBV cases had been reported, what had been to them, or whether they were in the justice process. Documentation is incomplete. Tracking is absent. Accountability is impossible without data. So those are actually some of the gaps that we observed when you compare with the global standards. When it comes to the recommendation, so based on everything we have presented today, the assessment identified, 7 priority recommendations. I'll move through them quickly. The first one is capacity building for police and health workers, because both counties need comprehensive practical training, regular refresher training with supervision and accountability mechanism. So that's one. And establish one-stop center at the county level, especially the Kajok model works, right? It must be replicated in Twic County at minimum. So survivors should not have to travel all day and pay for transport. They can't afford to access even, integrated services. Mainstreaming GBV as a cross-cutting team. I know we have an expert here. So every sectoral program, health, nutrition, wash, livelihood should integrate GBV awareness, safety protocol, referral linkages. So that's one of our recommendations. Advocacy for legal and judicial reform. So partners must actively lobby for the recruitment of more judge and even, governmental legal officer in Warrap state. So free or legal must be made available. Mobile courts also must be funded or operationalized. The other one is expand livelihood and economic empowerment. So I think this Women for Change model in Gogrial was demonstrate, the power of economic autonomy, and even supply health facilities with essential equipment, gloves, PPP kits, rape kits, basic medical supplies must reach all facilities regularly. So government and partner must establish dedicated, for clinical management of rape communities. And also, finally, promote gender inclusive GBV programming. Especially boys and men also experience GBV and present a significant even proportion of reported cases, especially males in Twic county, services and program must be even, designed to be inclusive across gender, age, disability, and even displacement classes, which is, consistent with ISAC 2015 GBV guidelines. I think let me stop here. Thank you very much. So thank you very much. The assessment we found today is not just, it's a diagnostic. It is a call to action grounded in rigorous evidence and amplified by, the voice of the people whose lives, depending on getting this right. So the recommendation we have outlined are not aspirational. They are visible. They are evidence-based and they are urgent. Thank you to each of our presenter for sharing, such rich and even practical insight from the field. We invite our colleagues, our partners, our donors, even, the global evaluation community gathered here, today to join us in making them real. So thank you very much and enjoy the rest of your day and night. Maybe if you have any questions, I think. Okay. Any question? Okay, yeah. Thank you very much and enjoy the rest of your day and night. Yeah. Thank you. Bye.
Thank you. Bye.
Thank you.